Okay, so welcome everyone. This will be our fourth webinar session of the year 2023. Today we'll be talking about seizure and epilepsy and seizure disorder in children. Our presenter will be Dr. Endayen. Dr. Endayen is currently working in St. Paul Hospital and an associate professor of pediatric neurology. Dr. Endayen attended his medical school at Jimma University undergraduate and studied pediatrics as well in undergraduate in Jimma. And he did his neurology fellowship, pediatric neurology fellowship in Black Lion Hospital in Ethiopia and CMC Valor in India. CMC is particularly well known for their neuroscience, gastroenterology, and hematology science. So I think today we'll be having an exciting session with Dr. Endayen. Uh, Everyone, it's a pleasure to have you here. So we will have a little bit introduction about YetenaWeg and we will shortly proceed to the webinar. So ይታያል አይደል everyone?
Yes, we can see it.
Okay, so YetenaWeg, it's a volunteer network of healthcare professionals. Currently, we have around 135 volunteers all over the world from different countries, and we have lots of wings to work on. Currently, the main areas of work for us are health promotion, clubhouse discussion, health advocacy on mental health, cancer care, disability inclusion, community outreach, mentorship, CME, and research. We will talk a little bit about each one of these. So regarding health promotion, currently we have articles we have published on our websites on different languages. We have podcasts. We have around 38 published podcasts already. You can find our podcasts on Google Podcasts, Spotify, Taraki, and Apple Podcasts as well. We also have regular clubhouse discussions. On these clubhouse discussions, we have experts, and it's also open for the general population. Everybody joins, and every now and then we have these topics we discuss about. So if you're interested, you can also check our clubhouse discussion. We try to promote healthcare and clarify and create awareness on lots of things on that one. We also have a health advocacy project on mental health with high school students that we're currently working on. We also have had lots of disability inclusion trainings. One of the things I would mention here is we had disability training, sign language training with healthcare professionals, and we also had a collaboration with Stucky Paperbacks on SRHR training. On our community outreach, we have lots of multiples of blood donation campaigns, charity programs that we try to integrate the group with the society. We also have a mentorship program. On this mentorship program, in the last 4 rounds, we have had around 462 mentees with 100 mentors. And on this mentorship program, what we do is we provide healthcare professionals and medical students a chance to be mentored by one of the people who have already reached the higher ceilings in their own respective fields. So what we have is students and medical professionals with their respective interests. So we link them with their professionals in a matching program. After the mentors have been matched, they will have 1 year. Then at the end of the day, at the end of the year, we will also certify the mentees as well. On the CME and research project, I will talk a little bit in depth. Bear with me. So we have regular same sessions. This YetenaWeg prepared regular same sessions are in partnership with most of the time EMA or ACP and EDFS. We also have lots of partnership we're currently established. So we have had around 30 sessions in the last year, and this year we're planning 40 plus. It might reach 45 or 50. It's just the fourth one, this one. So stay tuned and join us. You can follow up on our sessions. If you have missed sessions, you can find them on YouTube. We have a YouTube channel. Khalid, can you share the link on chat and everybody you can join as well. So regarding on our where to get information about our upcoming CMEs, you can find us on our Telegram channels. You can follow us on social media posts, Twitter, Facebook, LinkedIn, every social media we are. So you can find us there. Make sure to tune in, and we will share updates constantly. So we have around 36 or more sessions remaining. So I think they will be very beneficial for everyone. Regarding our research fellowship, currently we're conducting in collaboration with Roha Health. So I will talk a little bit about that. Currently, the mission of this research project as a whole is we want to increase the versatility of healthcare workers, and we want to improve research. We want to integrate applying scientific researches into healthcare practice. We want also to create a platform where healthcare professionals can initiate and execute their pursuit of academic research. We want to establish a network of Ethiopian researchers to have an exchanging platform. And we also want to create a space where health professionals can showcase their research and endeavor lots of others and to be inspired. So in this program currently, we're working with Addis Ababa University's Medical Faculty and St. Paul Hospital. So we have already started. We have launched the project, and the competition will start. We already started with with Addis Ababa University Medical Faculty. We have 3 departments we're currently working with: oncology, radiology, and internal medicine. So research abstracts will be submitted, and they will be evaluated by set criteria of experts. And after that, research grants will be given for 3 winners and mentorship for 10 winners. Regarding the one we're doing with St. Paul, we have it's targeting medical students, since St. Paul medical students are supposed to prepare research on their final year on internship. So it will be for them. So research grants will be given for 2 winners, and we'll have mentorship for many more. All this is sponsored by Roha Health. I would like to thank them very much for this. Our grants and everything regarding this thing, every cost and every mentorship program is currently being sponsored by them. We would like to thank Roha for this. So, and another collaboration we have with Roha right now, it's an article writing competition. So we have had 2 rounds before, and this is the 3rd round. This one we prepare with in association with Ethiopian Medical Students Association, IMSA. So what we do is we will have lots of competition, and after that, the winners will be rewarded. So top 5 winners will get internship opportunities. We will award the stethoscope for top 3 winners and oximeters, pulse oximeters for top 20 winners. And Roha Medical Campus will also give a grant for 2 winners to have a travel in their IMSA. When they have a IMSA travel or meeting, they will be granted a grant. They will be given a grant. So this is what we are doing right now. Regarding today's webinar, I will say little things about the house rules or what we do for the best experience. Then we will move on with our presentation. So if you have any question regarding the presentation or any question regarding the slides or anything, do not forget to send the question to the chat box. We will have a question and answer session at the end of every webinar. So we will make sure your questions are answered. And at the end of webinar, you can speak to the speaker as well. So to get the CU certificates, there are some sets of criteria. Attendees must fulfill. One of those is you have to attend the whole session virtually. So the minutes are checked by the Zoom attendee reports that sends us after the meeting. So you have to fill the Google form for personal details and attendance as well. Then the last one is after we will have a post-webinar quiz. So on that, you have to score 50% and above. So you will get your results right away. The results will be seen on the Google form as you finish, but certificates will take 1 to 2 weeks because IMA needs to evaluate, will prepare a list, and they will send you back on email. So if you don't receive your certificates in 1 to 2 weeks time, you can email us and acknowledge. We will respond promptly. So this is all. I will leave the stage for Dr. Endayen, and that's it. Thank you, everyone.
Okay, thank you very much, Mustafa. Thank you very much. And I really appreciate IMA and YetenaWeg for giving me this big opportunity. So today we'll have a discussion on epilepsy in children. So this is a bit vast topic, but I'll try to minimize it. So this is the outline of our topic today. So we'll see the introduction, then we'll have discussion on epidemiology, definition of classification of epilepsy and seizure. Then we'll have some discussion about epileptic syndrome and the management principles of childhood epilepsy, status of epilepsy, and finally, we'll have discussion on febrile seizure. So when it comes to the introduction, epilepsy is the fourth most common neurological disease following migraine, stroke, Alzheimer's disease, and dementia. So there are many gaps in care of epilepsy, like access, prevention, education, and stigma. So the comorbidities of this epilepsy is very vast, including both somatic and neurologic, like autism spectrum disorder, mood disorder is common in children having epilepsy, and somatic disorders following epileptic skin injuries, following extensive epilepticus, fractures that are associated with epilepsy. When it comes to the epidemiology, approximately 65 million people worldwide live with epilepsy, and the community lifetime incidence is 3%, and more than half of this disorder starts in childhood. And when it comes to this, see the definition, a seizure is a transient occurrence of silent symptoms resulting from abnormal or excessive synchronized neural activity of the brain. And epilepsy is a disorder of the brain, and there should be an enduring disposition to have subsequent recurrent seizure. So that resulting towards cognitive, neurobiological, psychological, and social consequences. So this is the operational and practical definition of epilepsy. Before 2017, epilepsy was defined as two or more unprovoked seizures that occur more than 24 hours apart. But this definition by itself doesn't fetch more cases of epilepsy. So there is some revision was made. So based on this revision, one unprovoked seizure, if the chance of recurrence is more than 65% and above, you can say that's epilepsy. Let's say a child having some cortical malformation or following post-meningitis sequelae. So if he is having one seizure, the chance of recurrence is more than 60%. So you can say that you can really diagnose as epilepsy. And the other is a diagnosis of epilepsy syndrome. So if you diagnose any epilepsy syndrome in children, you can diagnose epilepsy. So seizure is can be resolved with epilepsy can be resolved with those individuals who are age-dependent epilepsy syndrome that pass that age, or those who have remained seizure-free for the last 10 years with no seizure in the last 5 years. So epilepsy syndrome is a syndrome that manifests a typical age of onset. For example, an infant having West syndrome that usually manifests during infancy, or other epilepsy syndromes like Lennox-Gastaut syndrome that manifest during childhood. So there are specific age of onset and seizure type. For example, an infant having West syndrome of seizure type is predominantly the infantile spasm, or Lennox-Gastaut syndrome, tonic seizures and the atypical absence are predominant seizure types. And there are specific EEG characteristics for this epilepsy syndrome. And we have to, well, there are also other features that permit the diagnosis of epilepsy syndrome. And this is very important to further guide and management of and prognosis. The other important thing.
كان انتنا now ትንሽ ከፍ ብታረጋት ኤርፎኗን ድምጽ ይርቃል.
እሺ
Yes, very much better. Thank you.
Thank you, Shafik. So an epileptic encephalopathy is an epilepsy syndrome in which there is a severe EEG abnormality that is thought to result in cognitive or other impairment. For example, you can say epilepsy with continuous spike and wave during sleep. So in this kind of problem, there is continuous spike and waves that occur during sleep that result in cognitive impairment. Subsequently, the child loses his developed milestones. So when it comes to the classification, for the past 35 years and more, the seizure is classified into generalized onset and partial seizures. So due to lack of this classification doesn't catch more seizure types. So this classification was revised in 2017. So the classification have three important basic parameters. The first one is the brain where the seizure begins. It could be focal onset, or it could be generalized onset, or level of awareness during the seizure. So during the seizure activity, the child could be aware, the child could be unaware, or sometimes the families or the caregivers might not describe for you about the awareness, so we can say unknown awareness, and other features of the seizures, like it could be sensory or autonomic, or behavioral problems can be manifested as seizure. So this is the 2000 International Against Epilepsy classification of seizure and epilepsy. So as we discussed before, seizure could be focal onset seizure or generalized onset. In focal onset seizure, the level of consciousness could be retained or impaired awareness. So this focal seizure could be motor seizure, non-motor seizure. So for motor seizures like automatism, hyperkinetic seizure, atonic seizure, or myoclonic seizures are these motor seizures. The non-motor seizures are like autonomic seizure, behavioral arrest, cognitive, emotional, sensory are the non-motor seizures. Or the seizure could be focal to bilateral, the previously called secondary generalized motor seizures. The generalized motor seizures could be tonic, clonic, atonic, and so on. So this is the important classification from 2017. And the level of awareness, as we discussed, could be retained or impaired awareness. The other important thing is classification of epilepsy. So epilepsy can be classified into structural, based on etiology, metabolic, genetic, or unknown epilepsy. When you say structural epilepsy, if there is structural problems that result in epilepsy, let's say the child have congenital cortical malformations, or like post-hypoxic ischemic encephalopathy resulting in neuronal damage that results in structural epilepsy. So a lot of conditions might result in structural cause of epilepsy. The other cause could be metabolic epilepsy. When you say metabolic epilepsy, these epilepsies are as a result of problems in metabolic pathways, like urea cycle defects, pyrolysis-dependent epilepsy. So a lot of metabolic disorders might result in epilepsy in children. The other important causes are genetic epilepsy. So currently, a lot of gene mutations associated with epilepsy. For example, sodium channel mutation, potassium channel mutations, and CDLK5 gene mutation. So these all gene mutations might result in epilepsy in children. After evaluating all above problems, sometimes you might fail to reach the cause of epilepsy. So at this time, you can say unknown onset of epilepsy. So this is one of the structural epilepsy. Here you can see the T2 flare image. There is hyper-intense region in the left hippocampus. So this is one of the mesial temporal lobe sclerosis. That's one of the structural epilepsy. Here we can see there are hyper-intense region in the frontal right. Okay, so this is one of the important structural cause of epilepsy. Here we can see the focal cortical dysplasia, the hyperintense region, the T2 flare image. So this, you can see this is structural epilepsy. So when it comes to see the focal seizures, up to 50% of seizure in children can be focal. Some say it can reach up to 60%. Usually these focal seizures are underdiagnosed in most of follow-up clinics due to lack of like taking the proper history and physical examination. So this focal seizure can be classified into focal seizure with preserved awareness These are previously called simple partial seizures. And the other are focal seizure with impaired awareness, previously called complex partial seizure, and focal to bilateral clonic seizures. These are previously called secondary generalized seizures. So, sorry. So these seizures usually last 1 to 2 minutes, often preceded by an aura such as rising abdominal feeling, deja vu, sense of fear, or complex visual hallucination, micropsia or macropsia. So these children, for example, child having temporal lobe epilepsy, they will see things larger or smaller, and generally it's difficult to characterize sensation. Frontal lobe epilepsies, like focal sensation, like parietal lobe, if the origin of the seizure is from parietal lobe, or simple visual experience like from occipital lobe epilepsies. Usually children less than 7 years cannot explain about their auras. And subsequently, these children will have automatism. So this automatism is commonly occur in these children. And they will have also contralateral dystonic posturing of the arm, the head, the eye, unilateral, bilateral tonic arm stiffening could be there. So automatism is commonly occur in these children. This automatism could be oral, like chewing, or it could be walking or shuffling of the legs, and so this could be a part of focal seizure. Generalized seizures could be motor seizure or non-motor seizure. The non-motor generalized seizure is an absence seizure. It's one of the most common type of seizure in children. Usually starts at 5 up to 8 years of age, and two essential components are there. One, a clinical component manifesting with impairment of consciousness. So we call it absence. So brief absence episode without post-ictal period are one of the manifestation. And we have the EEG component manifesting with generalized spike and slow wave discharges. We call it 3 up to 4 years discharges. So this is typical absence seizure, an EEG 1, 2, 3. Here you can see spikes followed by slow wave, 3 spike and slow wave discharges. So one of the important EEG feature of an absence seizure. So this typical absence, this absence seizure can be classified into typical and atypical absence seizure. The typical absence seizure usually start at the age of 5 up to 8 years of age, and these typical absence seizure are very brief, so usually overlooked by families and the teachers and the school. So it can occur up to 100 times per day. So these do not have post-ictal period and characterized by immediate resumption of what the patient is doing before the seizure. And the other important feature for this typical absence seizure is 3-minute hyperventilation can reduce this typical absence seizure. So we can ask the patient or his child to breathe deep for 3 minutes, so he will have this absence episode. The other type of absence seizure is atypical one. This atypical one usually associated with other severe type of epilepsy syndromes. Usually other myoclonic components also could be there. And the EEG characteristics is, it's not 3 years spike and wave discharge. The 1 to 2 years spike and slow wave discharge are the manifestation on EEG of atypical absence seizure. The other commonly encountered type of seizure in children is generalized tonic-clonic seizure. Usually the tonic phase followed by clonic phase. So the child initially have the tonic phase, and the clonic subsequent phase will occur. Usually incontinence and post-ictal period often follows after this generalized tonic-clonic seizure. And this post-ictal, they will have post-ictal period, unlike that of absence seizure. So this post-ictal period could be prolonged, could be associated with obtundation, post-ictal sleepiness, weakness, ataxia. Sometimes they could have hemiparesis, post-ictal torus paralysis could be there. So the risk of aspiration in this generalized tonic-clonic seizure is usually could occur. So the important measures should be taken is the ABCD of the life. We have to maintain the airway. The child should be put on oxygen, and we have to check for the cardiac function. We have to check for the pulse rate and the volume, blood pressure. And we have to try to check for the glucose concentration. We should not forcibly open the child's mouth, and we should not put on anything on the mouth, including the finger and so on. So the risk of aspiration is very high. The other important motor seizures are the myoclonic seizures. So these seizures are very brief type of sudden muscle contraction. So sometimes these myoclonic seizures could be benign, but usually associated with other forms of encephalopathic type of epilepsies like Lennox-Gastaut syndrome, childhood absence epilepsy, Dravet syndrome, and myoclonic astatic epilepsy. So the other important topic in pediatrics epilepsy is epileptic syndromes. So it is said that about 30% of children having epilepsy could have this epilepsy syndrome. So these are an electroclinical syndrome. As we discussed before, these have a typical age of onset, seizure type, and specific age characteristic. And there are also other features that help for the diagnosis of this epilepsy syndrome. This diagnosing this epilepsy syndrome is important for the prognosis and management of the patient. So these are classification based on the age of the epilepsy syndrome. We have neonatal age, during infancy, childhood, and during adolescent. So during the neonatal age, we have, so based on the age, this epilepsy syndrome could be encephalopathic or benign. For example, in neonatal age, we have 4 types of epilepsy syndrome. 2 of them have benign, 2 of them have encephalopathic. From the benign ones, benign neonatal seizure, benign familial neonatal epilepsy, these are benign, self-limiting, the newborn outgrow from these seizures. But other encephalopathic types are O'Hara syndrome and early myoclonic encephalopathy. These are very severe forms of epilepsy. So these infants either will die early or they will have significant neurodevelopmental disability as the child grows. The other are like during infancy, we have like encephalopathic one, Dravet syndrome, West syndrome, benign one, benign familial infantile epilepsies. During childhood, we have the benign one like benign Ronaldic epilepsy or encephalopathic one, Lennox-Gastaut syndrome, CSWS, Endayen syndrome. And so a lot of encephalopathic epilepsy syndrome could occur during childhood. So this is during adolescent, and we have the variable age of onset. So when it comes to see about West syndrome, it's one of the most common epileptic encephalopathy during infancy. So these have 3 important characteristic features. Clinically, these infants have epileptic spasms, and on EEG, we will see they will have hips arrhythmia on EEG, and they will have also developmental regression and cognitive impairment will occur during the seizure. So the onset is typically 3 months up to 12 months of age, and the classic type of seizure in West syndrome is epileptic spasm. So these spasms are like brief contractions of the axial and the truncal muscles, but usually a bit longer than the myoclonic jerk and a bit shorter than the tonic seizure. And the other important feature of these spasms are usually occur in clusters. So it doesn't occur just as a single episode, it occurs in clusters. So that means the child could have 5, 6, or 10 clusters of spasm per day. And each cluster, he will have 3, 4, 5, and more spasm could be there. And the other important feature of these spasms are usually occur during awakening of the sleep. We call it the hypnagogic, or when the child is going to sleep, hypnopomic type of spasms. This is the typical EEG feature of the infantile spasm. We call it hypsarrhythmia. You can see high voltage, multifocal, high amplitude, sharp wave, and slow discharge can be seen here. And overall, the development and outcome of infantile spasm is poor, especially in children having severe brain malformation tend to have worse prognosis. So this is and the other important thing is in West syndrome, we need to follow them with MRI. Initially, the MRI could be normal, but subsequently you have to take MRI every 6 months up to 2 to 3 years of age, because we have to see changes of myelination. So during change of myelination, there could have some abnormality. So this is one of the MRI, a child having waist syndrome with tuberous sclerosis. You can see we have subendymal nodules here, and we have cortical tubers here. So we need to follow them with MRI. So we'll discuss about the options of management on the coming slide. The other epilepsy syndrome is a Dravet syndrome. We call it severe myoclonic epilepsy in infancy. So initially, these kids have normal development, usually up to 8 months and 9 months of age. Then usually begins the first 18 months of age. Then they will start to have fever-induced focal seizures initially, usually associated with fever. So sometimes misdiagnosed as febrile seizure. And in early childhood, other seizure type emerge. So as the child grows up to 1 to 2 years of age, the child starts to develop other type of seizure, especially the myoclonic and atypical absence seizure. The most important cause for this Dravet syndrome is the sodium channel 1 mutation. So one of the important genetic epilepsy. So these are diagnostic tips for healthcare workers, for all, especially for pediatricians, when to suspect a child having Dravet syndrome. So usually, as we discussed, occur during infancy, so before 1 year of age, and the fever-associated prolonged seizures, 15 or 30 minutes, usually unilateral, mainly chronic seizure, and frequently occurring and precipitated by low-grade fever, less than 38 degrees Celsius, and the age of onset is less than 1 year of age. And they will have also concurrent non-febrile seizures. The other important feature is as the child grows, as we discussed before, he starts to develop myoclonic jerks and mental deterioration, cognitive impairment, and so on. The other benign type of epilepsy in childhood is benign childhood epilepsy with central empire spikes. We call it benign Rolandic epilepsy. So benign Rolandic, the name is indicated, the EEG abnormality arises from the Rolandic area of the brain, the frontotemporal area, and seizure typically occurs shortly after the child falls asleep. So usually nocturnal onset during sleep. Sometimes 1/4 of patient could have during wakeful state, but usually these seizures are very infrequent, maybe 1 time per month, 2 times, 1 time per 2 months, 3 months, like that, infrequent seizure. And the other cardinal features of this benign Rolandic epilepsies, usually facial sensory motor symptoms or pharyngeal manifestation like sense of gagging, gurgling, suffocation. Usually the families can clearly describe about this type of seizures, and speech arrest in 40% of patients, hypersalivation in 30% of patients could occur. And this hemifacial sensory motor seizure often entirely localized in the lower lip or spread to the ipsilateral hand. And there could have also secondary generalized motor seizure could occur. So most of these children will outgrow seizure by age of 13 years. So developmentally, these children are normal. Sometimes status epilepticus occur in this kind of children. The other type of seizure in childhood epilepsy syndrome is Duce syndrome, previously called epilepsy with myoclonic astatic. Currently, it is epilepsy with myoclonic atonic seizure. So age of onset is usually 3 years of age. It can start from 18 months, but up to 5 years of age. So myoclonic astatic is the predominant type of seizure, 100% of cases. There is myoclonus followed by atonic seizure. So this manifests with symmetrical myoclonic jerks, immediately followed by loss of muscle tone. So post myoclonic atonia is commonly occur, and atonic seizures often sudden and brief, and with severe loss of postural tone may involve whole body or only the head. And absence and tonic seizure could occur in this type of, but it's not commonly occur. But atypical absence could be one of the manifestations for Duce syndrome. So usually like 50 up to 89% of children will outgrow, but the remaining minority could be refractory for different type of medication. So they are candidate for other type of epilepsy management like ketogenic diet and so on. So we'll discuss about briefly about the management. The other important encephalopathic type of epilepsy syndrome in children is Lennox-Gastaut syndrome, one of severe form of epileptic encephalopathy. So 3 important features are there: intractable seizures, commonly tonic, atonic, and atypical absence could be there. And the child could have cognitive and behavioral abnormalities. So child could be initially normal, but then he will develop developmental regression, cognitive abnormality. Then EEG characteristic is less than 2.5 years spike and wave discharge. In absence seizure, they will have 3 years spike and wave discharge, but in Lennox-Gastaut syndrome, the EEG characteristics less than 2.5 years spike and wave discharge. Peak age of onset is 3 up to 5 years of age. The other important feature in the epilepsy syndrome in children is one form of epilepsy syndrome could transfer to the other form. For example, a child with a newborn with Ohtahara syndrome might progress to West syndrome, then West syndrome might progress to Lennox-Gastaut syndrome. So 20 to 40% of cases of Lennox-Gastaut syndrome as before they were diagnosed as West syndrome. So up to 30% of patients with LGS have no known etiology, but the more common form of etiologies are like cortical brain malformation, tuberous sclerosis, infections like encephalitis, and genetic epilepsies could be contributing cause for Lennox-Gastaut syndrome. So this is the EEG characteristic for Lennox-Gastaut syndrome. We can see 2 years spike and slow wave discharge, 1, 2, you can see 1, 2. So this is a characteristic for Lennox-Gastaut syndrome. So the progress is very poor, despite availability of many newer anti-seizure medication. The seizures are usually refractory for the treatment. So the other important thing we will discuss is the management principle of childhood epilepsy. So the goal of treatment in patients with epileptic seizure is to achieve seizure-free status without adverse effect. So up to 70% of individuals with active epilepsy will be seizure-free with anti-seizure medication. So, but the remaining 30% of individuals are refractory for most of anti-seizure medications that might need additional options of epilepsy treatment. So, so after a first seizure, so as we discussed first about the definition of epilepsy, one, there should be, if the child have 2 or more unprovoked seizures that should occur more than 24 hours apart, or 1 unprovoked seizure, the chance of recurrence is more than 60%, we can say epilepsy. But with 1 unprovoked seizure, if the child developmentally normal, the age is normal, and MRI is normal, the chance of recurrence is 20%. So we don't need to start him on anti-seizure medication. So what we have to do is we have to follow the child. But if the patient has an abnormal EEG, MRI, and developmental status with 1 unprovoked seizure, we can initiate him on anti-seizure medication. So another consideration is we need to see the functional status of the child to initiate the anti-seizure medication. So as we know, so this is so we have 2 types of transmission on the brain neurons. So we have GABAergic and glutaminergic transmission. So most of anti-seizure medication act on this type of transmission. On this side, we can see the drugs act on the glutaminergic transmission. Glutamic is one of excitatory neurotransmitter. Here on this side, we can see the GABAergic neurotransmission. So in the glutaminergic transmission, we have the voltage-gated sodium channel. So here we have drugs that can inhibit the voltage-gated sodium channels like phenytoin, carbamazepine, oxcarbamazepine, lacosamide, zonisamide, lamotrigine are the drugs that act on sodium channel. The other important drug, the newer anti-seizure medication that act on synaptic vesicular protein that stabilizes the membrane. This synaptic vesicular protein is levetiracetam, and other drugs like important drug that act on T type of calcium channel is toxosomide. Knowing this is very important for combination of anti-seizure medication and for treatment of type of seizure. The GABAergic transmission, here we can see the most known, well-known drugs act on the GABA A receptors are the barbiturates and benzodiazepams. The barbiturates result on prolongation of this GABA A chloride receptor, and the benzodiazepams resulting on frequency of opening of this GABA A receptor. There are also other classes of drugs like retigabine, that's a very important drug that can block the potassium channel. And we have also gabapentin and tigabine. So we have a lot of anti-seizure medication with different mechanism of action. So when you consider to initiate the child on, once we diagnose epilepsy, when you consider to initiate him on anti-seizure medication, we need to follow these important points. One, the aim of anti-epileptic treatment is to achieve seizure freedom without adverse effects. So we have to always carefully follow for adverse effect. The other important issue is the first option of anti-epileptic drug is the most likely efficacious and the most unlikely to cause adverse drug reaction. And the correct anti-epileptic drug dose is smallest ones that achieve seizure control without adverse drug reaction. And appropriate for one type of seizure might have deleterious effect for another type. For example, carbamazepine might aggravate absence seizure. Sodium channel might aggravate having children having like sodium channel mutation type of epilepsy, like Dravet syndrome. So we need to be carefully select our anti-seizure medication, and we have to titrate to the limit of tolerability may improve anti-seizure efficacy, but often at the cost of adverse reaction. And optimal efficacy of anti-epileptic drug may be lost by exceeding tolerability limits. So you have to carefully escalate to the optimal dose. So when prioritize to choose anti-seizure medication, we have to consider these important principles. One, we have to consider the seizure specificity. So that means whether the child have focal seizure or generalized seizure. For focal seizure, we need to start in like carbamazepine, phenytoin, and so on. For generalized seizure, we need to use other type of agents like valproate. Sometimes we can use phenytoin, phenobarbital, and so on. So we have to choose based on the specificity of the seizure, strengths of efficacy. So we have to always choose the more stronger ones than the other. For example, for myoclonic seizure, valproate is more stronger than for others. So we can choose the more stronger one. And the spectrum of efficacy. That means, let's say, carbamazepine have efficacy on focal seizure, valproate, levetiracetam have more broad spectrum of action, so we can choose that. And we have to use safety. For example, using valproate in infant is very, sometimes could be very fatal due to the hepatotoxicity. So you have to be careful when you start in valproate, especially less than 2 years of age. And tolerability, adverse reaction, particularly if they are severe and life-threatening, like lamotrigine-induced hypersensitivity reaction, is commonly occur in young children. And we have to use the pharmacokinetic, pharmacodynamic, and drug-drug interaction should be kept in mind by before initiating the anti-seizure medication. The speed of titration. So we'll see some of the examples in the next slide. So as we discussed before, the drug of choice for focal seizure and epilepsy is oxcarbazepine and carbamazepine. For absence seizure, toxosomide is drug of choice, but valproate can be used as equally effective. For juvenile myoclonic epilepsy, valproate and lamotrigine are a drug of choice. For Lennox-Gastaut syndrome, like clobazam, valproate, topiramate, and lamotrigine is a drug of choice. For infantile spasm, adrenocorticotropin hormone or steroid like prednisolone are a drug of choice. A spectrum of efficacy, sometimes it's difficult to differentiate between focal versus generalized seizure. At this time, it's better to use the more broad spectrum ones like valproate, levetiracetam, topramate, and zonisamide. So the other important principle is, as we discussed before, we have a lot of gene mutation might be associated with epilepsy in children. So sometimes it's better to do the epilepsy panel genetic testing. So we have, it can be done in Addis. So some of the epilepsy panel can be done. For example, sodium channel mutation, potassium channel mutation, green mutation can be done here in Ethiopia. So it's very important to do that, because it's helpful to select the medication of choice. For example, if a child having ALDH7A1 mutation, you can start him on pyridoxine. KCNQ2 mutation can be started on retigabin, especially loss function mutation. For sodium channel 1 mutation, that's the Dravet syndrome, we have to avoid using the carbamazepine or carbazepine and amotreginine. These are sodium channel blockers. For sodium channel 2 mutation, phenytoin and carbamazepine can be used. Usually this is benign form. Sodium channel 1 mutation is encephalopathy. It's associated with Dravet syndrome. The other important principle is adverse reaction may outweigh any beneficial effect. So we need to be careful when you start medications like lamotrigine. For example, it said that when you start lamotrigine, you have to start very low and go very, very slow. That means you have to start like the smallest maintenance dose, like 0.15 milligram per kg, then start to escalate every 2 weeks, not in days or hours. So you can reduce the chance of having hypersensitivity reaction. For clonazepam, we have to start low and go low. So these are benzodiazepines, long-acting benzodiazepines. So the sedative effect is very low. So we have to wait for the child to tolerate the medication. The other important thing is potential for paroxysmal seizure aggravation by some AED could be there. Precipitation of myoclonic seizure by lamotrigine in Dravet syndrome. Carbamazepine might aggravate absence seizure. And you have to see adverse effect value according to the profile of patient. So children less than 2 years, malnourished children, some metabolic disorder might be worsened by using valproic acid. So we have to be carefully monitor the liver function test. Those are the commonly occurring adverse drug reaction on children with epilepsy. So carbamazepine can be associated with idiosyncratic crash, sedation, headache, ataxia. Most of sodium channel blockers are usually associated with ataxia and tremor and so on. So commonly associated and also could have idiosyncratic reaction. Clobazam and clonazepam associated with severe sedation. They are long-acting benzodiazepams. Toxamide could be associated with idiosyncratic reaction. Lamotrigine is one of the notorious drugs with Stevens-Johnson syndrome. So we need to be always careful. So that could be also fatal. And valproates could be associated with nausea, vomiting, weight gain, especially for adolescents. So we have to be carefully initiate on for adolescents. So weight gain could be there, hepatic and pancreatic failure could occur. The other important thing is drug-drug interaction. So we have mostly older type of anti-seizure medications, phenobarbital, carbamazepine, phenytoin. Most of them are hepatic enzyme inducers. So, for example, initiating valproate with phenobarbital. Phenobarbital is hepatic enzyme inducer. Valproate is hepatic enzyme inhibitor. So both of them have drug-drug interaction. So that results in we cannot achieve appropriate serum level of this anti-seizure medication. So the seizure outbreak of seizure could occur. So most of older AEDs are prone for drug-drug interaction. But the other currently available neuroforms like levetiracetam and gabapentin usually metabolized by the kidneys, not by the liver. So the drug-drug interaction profile is very low as compared to the older one. So the other important principle on initiating the child with anti-seizure medication, as we discussed before, like 30 to 50% of patients fail to respond for single drug therapy. So we need to consider initiation of the polytherapy. So these are the most important concept for polytherapy. So first, we have to select appropriate drug for appropriate type of seizure, appropriate type of age. Then we have to establish optimal dose of baseline agent. Let's say for focal seizure, we start carbamazepine 10 mg per kg. So start escalate up to 20 mg per kg. So when fail to achieve with 20 mg per kg, then we have to add drug with another mode of action. So we don't need to add, when you start carbamazepine, don't need to add phenytoin because they have both the same mechanism of action. They have sodium channel blocker. So we need to add additional a drug with another mechanism of action. It could be valproate, it could be phenobarbital, based on the type of seizure and the age of the child. Then after adding another mode of drug with another mode of action, we have to titrate it with slowly and carefully. Then we have to be prepared to reduce the dose of the original drug, and we have to replace less effective drug if response is still poor. Then try to arrange different dual therapies. So we have to try to use different dual therapies, and we need to also consider to add third drugs, especially in children having severe type of epilepsy syndrome like Lennox-Gastaut syndrome or sometimes Dussé syndrome, refractory for single or two medication. So when you say patients with drug resistance epilepsy, those who have failed at least two failed trials, so we have to use properly selected failed trials. So if we fail to achieve these two failed trials, we need to consider other type of epilepsy management. This could be, so first we have to evaluate other causes like mitochondrial disease, could be their metabolic problems, could be Rasmussen encephalitis. So we have to carefully evaluate for other possible underlying causes, and we need to start them on other options of epilepsy management. So when to discontinue, still it depends on the individual child. So the most important things are the length of seizure-free interval is important, the drug history is important, and neurologic and epilepsy syndrome diagnosis is important. So discontinuation of epileptic drugs usually indicated when children are free of seizure 2 years, but it's just a kind of rough guideline, because children having Lennox-Gastaut syndrome, severe microepilepsy like Dravet syndrome, so we need to treat them for long. Sometimes they might take this anti-seizure medication for lifelong. So the discontinuation based on the individual type of epilepsy and age of the child, duration of treatment. So other options of epilepsy management. So we have other important options of epilepsy management other than anti-seizure medications like ketogenic diets, neuromodulation in epilepsy, and epilepsy surgery. So we'll have some brief discussion about this ketogenic diet. These ketogenic diets are used for centuries for treating for many problems since biblical times. So these ketogenic diets are the diets with very low proportion of carbohydrates, so only 5%. So the energetic proportion of these keto diets are like 65% from fat, 30% from protein, 5% from carbs. And the aim of using this ketogenic diet is medically refractory epilepsy to achieve greater than 50% reduction in seizure activity. So despite long history and use of proven values, the exact mechanism of action is the diets remain unknown. There are some theories, and selection of candidates for these diets are those with medically intractable seizures, those with poor tolerance and significant side effects from anti-seizure medication, those with intractable seizures who are being considered for epilepsy surgery like corpus callosotomy, and was those with specific neurometabolic disorders and neurologic symptoms. So these are important specific candidates for ketogenic diet, like glucose transporter deficiency syndrome, pyruvate dehydrogenase complex deficiencies, are some metabolic problems, infantile spasms, Duce syndrome, severe myoclonic epilepsy, infancy Dravet syndrome. So these are important indication for ketogenic diet if they are refractory for medical management. And these are specific contraindication for ketogenic diet. So we need to first screen for this metabolic disorder before initiation of ketogenic diet. For example, if the child having fatty acid oxygen defect, if you start him on ketogenic diet, that could be fatal. So we need to screen before initiation of this ketogenic diet. So it's a contraindication. So there are some selection criteria, and so for medical refractory epilepsy, it's very important to consider this ketogenic diet. Hopefully, in the coming future, we will start this ketogenic diet. So the other topic is about status epilepticus, one of medical emergency, and the incidence is very high in neonatal period and up to 5 years of age. So the definition of status epilepticus before 2015 is if the child having generalized tonic-clonic seizure more than 30 minutes, we call it status epilepticus. That definition was revised due to many reasons. So we have now 2 points of time, time 1 and time 2. So time 1 is very important time. So most of the seizure usually stop by itself, more than, you can say 80 up to 95% with less than 5 minutes. So once the seizure pass the 5 minutes, the chance of stopping by itself is very rare due to neuronal synchronization. So the time 1 should be taken as a 5 minutes for generalized tonic-clonic seizure. And we have another time point 2 that is for generalized tonic-clonic seizure. We took 30 minutes because after 30 minutes of seizure, there will be permanent neuronal damage could occur. That is hippocampal sclerosis. So we have to use this time 1 and time 2. So this time 1 and time 2 is different based on the seizure type. For, as we said, for generalized seizure, time 1 is 5 minutes. For NT2 is 30 minutes. For focal seizure, conform-based distinct, time 1 is 10 minutes. NT2 is 30 minutes. For absence seizure, T1 is 10 up to 15 minutes, T2 is undetermined. So mostly we will speak about the management on generalized tonic-clonic seizure. So 5 minutes, T1, T2, 30 minutes. So as seizure is one of medical emergency by itself, and if it is refractory, that could be fatal. So that's, we have to be carefully manage this type of children. So the most important thing as in all type of seizure is first you have to approach with the ABCD of life. So we have to secure the airway, as we discussed before. We don't need to put anything on the mouth. We don't need to put the finger on the mouth that might crash, that child could aspirate. So we have to secure the airway. You have to put in child oxygen. You have to check for shock, and child could have also hypertension due to many reasons. So you have to check for the circulation. And then we determine management of underlying etiology. So underlying etiology could be especially for acute symptomatic things like infections, hypoglycemia, electrolyte disturbance that should be addressed very well. So once the seizure passes for more than 5 minutes, we need to consider short-acting benzodiazepams. So we have 3 short-acting benzodiazepam, lorazepam, diazepam, or midazolam. So we have to use whichever is available. So diazepam can be given intravenous, or if there is rectal preparation, can use rectal diazepam. Lorazepam can be given IV. Midazolam can be given IM, IV, or intranasal. So whatever available can be used. Efficacy-wise, most of the study shows all are equally effective. And these are the dose of this short-acting anti-seizure medication. So administration of benzodiazepam may result in respiratory depression and hypertension. So we have to continuously monitor the child. And if the seizure doesn't terminate for 5 to 10 minutes, we might need to consider second dose of this short-acting benzodiazepam. So we can consider, especially in the ICU setting. So if the benzodiazepam fail to control status epilepticus, that lasts for more than 10 minutes, we need to consider longer acting anti-seizure medication. So the preferred one is the phosphenitoin. Usually phosphenitoin is not available in our country, so we have to use phenytoin, but still IV is recommended. Still we are using fewer ones, but phenytoin IV, when you give phenytoin IV, you have to always be careful that the child might develop arrhythmia hypotension. So it should be given slowly and carefully by monitoring the vital sign and EEG, ECG. And the most common second option when phenytoin or phosphenitoin fails to control is phenobarbital. So within 10 minutes, after 10 minutes to 15 minutes, you can use IV phenytoin. So if you fail to achieve with that, so the second option is you can use phenobarbital. But this is some guideline of management. So you can see 5 to 10 minutes independent status epilepticus. So we have to use phosphenitoin. So and the second 15 to 30 minutes, another option is phenobarbital, but we can use valproate or levetiracetam, whatever is available. If you fail to have, if you don't have the phenobarbital, then after 30 minutes, we call it established status epilepticus, that is refractory status epilepticus. So at this point of time, the child should be intubated on, and the child should be started on continuous infusion. So preferred one is the midazolam infusion. Usually, its side effect profile is much better than the pentobarbital and the other type of anesthetic infusions. So we'll discuss some of these drugs. Phosphenitoin is water soluble type of phenytoin. It's a prodrug and can be administered either IM or IV, and you can achieve after IV administration the peak immediately after administration, or after IM administration after 20 minutes of administration. And for seizure more than 15 to 30 minutes duration, second benzodiazepam can be used, and the most commonly used are the valproate, phenobarbital, valproate or levetiracetam. So these are the dosing dose for phenobarbital for IV. Valproate also can be given at 20 up to 40 mg per kg IV as second line option next to phenytoin or phosphenitoin. This is the dose for levetiracetam. So refractory status epilepticus, if you fail to achieve seizure control with one benzodiazepine plus 1 or 2 long-acting anti-seizure medication, so as that is usually 32 minutes to 1 hour, so we can consider refractory status epilepticus. So the child should be kept on the ICU and started on continuous infusion, and midazolam is the first line agent for refractory status epilepticus. And this is a dose for midazolam infusion. So still, that might result in respiratory depression and hypotension. So it's much better than the pentobarbital IV infusion. So another commonly, usually we have difficulty in getting this midazolam IV infusion practical in ICU setting. So we are using this pentobarbital or tiopental. So the risk of having hypotension and respiratory depression is very high. So the child should be continuously monitored with cardiopulmonary monitoring. And the third option is propofol, but the propofol usually associated with propofol infusion syndrome. This propofol infusion syndrome is lactic acidosis, hypertriglyceridemia, and rhabdomyolysis. So usually it's not recommended to give propofol for pediatric patient with status epilepticus. But if you don't have another option, you can use the propofol. And sometimes after giving this continuous infusion, sometimes we will fail to achieve the seizure control. So that's usually after 24 hours of this continuous infusion. If you fail to achieve seizure control, you can consider super-refractory status epilepticus. So the options of management for super-refractory status epilepticus are this: ketamine or inhaled anesthetics, ketogenic diets, or resective surgery can be also considered. So the last topic is, sorry for, I think it's a bit longer discussion, so this could be the last topic. So febrile seizure is one of, it's not, febrile seizure is not epilepsy, just one of seizure type of children. So usually it's one of the most common type of epilepsy in children. So it's a diagnosis of exclusion. So we need to exclude other type of acute symptomatic causes like meningitis or cerebral malaria, encephalitis that should be ruled out before diagnosing febrile seizure. So we can classify grossly this febrile seizure into simple febrile seizure and complex febrile seizure based on the onset. Usually for simple febrile seizure, onset is generalized. Complex febrile seizure, onset is focal. Duration is prolonged more than 15 minutes. It's less than 15 minutes for complex febrile seizure. Recurrence risk is low in simple febrile seizure. Usually there is no recurrence during 24 hours. So this is very important definitions of febrile seizure and classification of febrile seizure. And this febrile seizure recur in 30% of patients experiencing the first episode, and 50% of those more 2 or more episodes, and 50% of children younger than 1 year. And the presence of these neurodevelopmental abnormalities, occurrence of family history of epilepsy, and complex febrile seizure increase the risk of having the chance of recurrence. In general, it's not recommended to give long time antiepileptic therapy for children having febrile seizure. And patients should be considered about relative risk of, parents should be counseled about the relative risk of epilepsy. Is very important. So most of the mothers and families usually ask you about the relative risk of epilepsy. So you need to counsel them. For simple febrile seizure, chance of having future epilepsy is very low, almost as compared to general population. But if the child has some neurodevelopmental milestone abnormality, or who have complex features and focal type of seizure, might increase the chance of having epilepsy. And regarding the treatment, as we discussed before, all type of seizure, regardless of the etiology, should be treated as after 5 minutes, treated as status epilepticus. And lumbar puncture in children having fever with less than 6 months always should be done. But for children less than 6 months up to 12 months, if the child, the immunization history is incomplete, if you don't have any information about the immunization, we should do the LDP. And the other important thing is, if the child is treated with pre-antibiotic, sometimes you might need to consider to do the lumbar puncture for children with febrile seizure. Thank you very much. Thank you very much. These are the references.
Thank you very much, Doctor. Yeah. Isra, you can continue.
Thank you, Doctor. It was actually a very intriguing and interesting presentation. I think everyone enjoyed it. I can see in the chat section as well, and from the emoji reactions. It was well prepared and well presented. Thank you for your time. So now we will proceed to the questions and answer session. We have few questions raised from participants, and in few minutes we'll also be sharing the Google form. So participants, please don't forget to fill the form and take the quiz to get certified. Saga, can you take over for the question and answer session?
Okay. Thank you, Doctor, for your excellent presentation. Everybody's liking it. We've got few questions in the Q&A section. The first one is, what other features of seizure are used to classify seizure? I think you have elaborated in your presentation. Can you tell us other features to classify seizure?
Okay, thank you very much. Thank you very much. So, as we discussed before, most of us think seizure as motor seizure, but the seizure could have a lot of manifestations, like seizure could be emotional, or sometimes children could have crying or laughing could be a seizure. Or as we discussed before, like numbness of the limbs, like sensory seizure, tingling of could be a manifestation of seizure. So the other features are the other important feature of the seizure. As we discussed, automatism could be a seizure, like nausea, vomiting could be a manifestation of seizure. So these are the other features of seizure. Thank you. I think the question is answered.
Thank you. The next question was, what do you mean by typical age onset in epilepsy syndrome? And if you could increase your voice, doctor, or if you could unplug the headphones.
Can you repeat the question? Sorry.
Okay. The question was, what do you mean by typical age onset in epilepsy syndrome?
Okay,
I think you are on mute. Yes.
Yeah, thank you very much. So typical age of onset means, so these electroclinical syndromes have typical age of onset. So these syndromes could start at neonatal age, could start during infancy, could start during childhood or during adolescence. For example, as we discussed before, epilepsy syndrome that usually start in neonatal age are like Ohtahara syndrome or early myoclonic severe myoclonic epilepsy, and benign forms like benign neonatal epilepsy. These are epilepsy syndrome that starts during typical age of neonatal age. And the other syndromes like West syndrome starts during infancy. So Dravet syndrome starts during infancy. So these are typical age of onset. So I think that's the question.
Yes, thank you very much. On your management section, you mentioned ACTH, and they were asking if we could find it in our country. And another question was added on that for the seizures that resolve with age and don't occur often enough. For example, benign neurologic seizure, is it necessary to start treatment or shall we just observe?
Okay, thank you very much for your question. So the ACTH sometimes you can get sometimes. So it's better to say it's not available in our country. So the next important option is high dose of prednisolone. So you can use, for example, for infants, 10 milligram QID. That means 40 milligram per day for 2 weeks. Then after 2 weeks, we will repeat the EEG and we will see the clinical improvement. Then we will start to taper that. So we usually using the prednisolone, other not the ACTH. The next question is about the benign neurologic epilepsy. So usually these seizures are, as we discussed before, infrequent seizures. So that sometimes occur at 6 months and so on. These children are neurodevelopmentally normal. So sometimes it's better to follow without initiation of anti-seizure medication. But sometimes they could have status epilepticus and sometimes could be frequent. So at that time, we can initiate them on carbamazepine. So we have to make it individualized rather than just treating all seizure with benign neurologic epilepsy.
Thank you. The other one was, what is the place of routine vitamin D supplementation during AED therapy? And added on that, what's your comment in routine MRI and EEG of brain for atypical febrile seizures?
Okay, thank you very much for the next question. So as we initially discussed, most of all the AEGs are hepatic enzyme inducers, so that might result in inhibition of this the hepatic enzyme like 25-hydroxy cholecalciferol. So most of these children, especially valproate, phenobarbital, phenytoin, lamotrigine, so that results in decrement of the vitamin D level. So at this time, you need to carefully monitor their vitamin D level, and sometimes we need to supplement them with maintenance dose of vitamin D. So it's better, especially for older anti-seizure medications. The other question is about MRI on complex febrile seizure. So usually these complex febrile seizures might last more than 30 minutes. So that we call it complex febrile status epilepticus. after 15 minutes. So at this point of time, if you did the MRI within 72 hours, sometimes we can see the hippocampal changes could be there. So hippocampal edema could be there. So within 72 hours, MRI can be considered. Some says, not all experts agreed on that. So, but if you consider there is some change in the hippocampus due to status epilepticus, you can consider to do brain MRI, but it's not routinely recommended to do the MRI. About the EEG and complex febrile seizure, usually if you do the EEG within 2 weeks of having seizure, you can only find some non-specific slowing, so it's not informative for anything. So if you consider to have EEG, you have to do after 2 weeks of febrile seizure. Okay, thank you.
Thank you. We have another questions, but meanwhile, our dear participants will be sharing the forum right now. You can be, you will be doing the questions, and meanwhile, we'll be answering your questions. The other question, doctor, was what is the main difference between absence seizure and focal seizure with impaired awareness? And added on that, if you can answer us the differentiation of simple and complex febrile seizure, can you please repeat it? They were saying. Sorry, you are in mute. Sorry, Doc, you're mute.
Second question, sorry.
The second question was the differentiation of simple and complex febrile seizure is not clear. Can you please repeat it?
Sure, okay, sure. Okay, so for how to differentiate focal seizure from absence seizure. So as we clearly discussed before, this focal seizure, patients and children having focal seizure have initially an aura could be there. So an absence seizure, we don't find an aura. The other important feature is automatism. Automatism usually doesn't occur in absence seizure, it occurs in focal seizure. And in focal seizure, in absence seizure, we don't have just brief usually. These absence seizures last for seconds, especially typical ones. So these children will resume their activity immediately after the seizure onset, and that occur multiple times per day. And they don't have post-ictal confusion or post-ictal period. So these are important features. So focal aware seizures, these children could have, for example, the manifestation of, if it's sensory, they could have some numbness. If it is some automatism could be there, like nausea, vomiting, or manual shuffling, and so on. So it can be clinically differentiated easily. Okay, and the other thing is about the simple febrile seizure and complex febrile seizure. So simple febrile seizures usually last for less than 15 minutes and usually generalized onset rather than focal onset. So simple febrile seizures are generalized onset and usually doesn't recur within 24 hours. So usually occur single episode within 24 hours. Thank you.
Thank you. The other question was belly dancer syndrome is a rare case, right? I think. Is it an epilepsy? They were asking if belly dancer syndrome is an epilepsy. Yeah, you're on mute, Doc, sorry.
So there are a lot of epilepsy mimics in children that starts from infancy, childhood, and adolescent. That could occur both during sleep and awake state. So, for example, there are a lot of the movements, that benign movement that could occur in infancy, like shuddering attacks that usually mimics infantile spasm and so on. So we need to clearly or carefully took the history, and we need to follow the child if you have any doubt about the epilepsy. So we have to evaluate the child carefully before we say this is epilepsy, seizure or not. Okay, thank you.
Thank you for answering the questions precisely. The other questions was, when do we stop seizure management admitted due to meningitis? And can we make it clear on the indications of lumbar puncture for febrile seizure?
Okay, so this is a very important question. Sometimes we will have on dilemma when to start on after initiation of anti-seizure medication following for acute symptomatic seizures or post hypoxemic insult and so on. So still, we always before discontinuation of this anti-seizure medication, we have to assess the chance of recurrence. So as we discussed before, epilepsy is a disorder of brain that is due to enduring capacity to have additional occurrence of or recurrence of seizure. So let's say a child having meningitis, if you develop meningitis associated complication, that could be ischemic insult, resulting on like stroke or hydrocephalus or whatever. So if the child have some underlying problems that might have further increased the risk of recurrence, so at this time we need to be careful before we discontinue the anti-seizure medication. But if the child is treated well and developmentally normal and the MRI normal, so we can easily discontinue the anti-seizure medication without any doubt. The other question is about LP, so on febrile seizure. So it is recommended to do all infants less than 6 months with fever. LP should be mandatory. From 6 months up to 12 months, if the child immunization starts not now, so if he's not taking the vaccines, especially the Haemophilus influenza type B and strep pneumonia, so we need to do LP. Or if the child is pre-antibiotic treated, we have to consider to do lumbar puncture. Thank you.
Thank you very much, Doc. The other question was for non-epileptic patients who were seizure-free for 2 years, but with subclinical seizure in the EEG pattern. For how long do we continue the AED?
Okay, so I think the question is only there is some EEG abnormalities that could be spikes, shockwaves, whatever on the EEG, but the clinical is seizure free. So it's better continue to still it's recommended to continue the AED until maybe 2 years or 3 years, and we have to repeat the EEG. If the EEG clearly shows, I'm not saying like slowing or unspecific slowing like that. If they clearly showing epileptiform discharges that are spikes, sharp waves, and so on. So at this time, it's better to continue the anti-seizure medication. Thank you.
Okay, we have got a lot of questions, but we will be restricting it for our last one. In case of diazepam, is there any rectal preparation, or we give the IV preparation rectally? And what is the boundary between psychiatry and neurology?
About regarding diazepam, there are Western setup or other setups. There are well-formed rectal preparations, but some experts in our setup we don't have this.
I think Dr. Endayen is having network problems. Our participants, please make sure to fill the form in order to get your certificates. And it might take us nearly 2 weeks to give you the certificates. Sure to join our social media platforms and make sure to follow us. Yes, Doc. We can see you now. Yes. You're on mute though. You're on mute.
I think the last question is about the psychiatry and neurology.
Yes, yes, it was.
Yeah, it's totally because there are psychiatry and there is a neurologist, psychiatrist and neurologist. So there is a big difference between the more of psychiatry is more focused on the like psychiatric disorders, like some behavioral disorders and psychiatric disorders, but neurologists more focus on organic problems and so on. So there are clear difference between that. Yeah. But nice question.
Yes. Thank you very much, Dr. Endayen. Thank you for your excellent presentations. Our participants liked it. They were texting us on the chat box that they really found it very useful in their practices. And thank you for answering all the questions they asked. And on behalf of YetenaWeg, we would like to say thank you for giving us this time to tell us your expertise on pediatric seizure and epilepsy. I would like to say thank you our participants, and please do be patient for us to send you the certificates. I've sent the form to answer the questions. If it is possible, Doc, if we can do the questions together after a few minutes, we can give them like 2 minutes to answer the questions, and we could answer the questions together. Okay, thank you. Let's give them 2 minutes and we'll be closing the form. So our dear participants, I can see 115 participants here. Please make sure to do the questions and we'll be doing it together. Meanwhile, I'll be sharing the links for the YetenaWeg. Make sure to check out the link tree and follow us in social media platforms to get another sessions that will be happening in 2023. We plan to have nearly 40 CMEs in this year. So do follow us in the social medias to know the exact hour and date of the next CME. Dr. Endayen, shall I open the questions or you can open it from your end?
Please, you can't open it. Thank you.
Okay.
So, shall I read the questions or?
Yes, you can.
Yeah, so the first question is about the classification of the seizure. So 5 years old male child presented with chronic movement of right upper limb in the past 6 months. So the movement lasted for 1 to 2 minutes without loss of consciousness. He has 2 to 3 episodes per week. So what is the seizure semiology of this child? A, left focal aware motor seizure. B, right focal to bilateral seizure. C, right focal aware seizure. D, generalized seizure. So here we have chronic movement of right upper limb, and he's aware during the seizure activity. So we call it right focal aware seizure. I think it's clear.
Yes, it is.
Yeah. Thank you. Can I proceed to the next question?
Yes, yes.
So the next question is, which of the following fulfill the criteria for definition of epilepsy? 10 months old infant presented with complex febrile seizure. So as we said initially, febrile seizure after epilepsy. So next option is B, 4 years old child presented with benign neurologic epilepsy. So this is one of epilepsy syndrome. So this is the answer, I think. And C is 1 year old child presented with 1 episode of unprovoked seizure. So 1 episode of unprovoked seizure. To say it is epilepsy, there should be some underlying problem, like child should be neurodevelopmentally abnormal, MRI showed some malformation. The chance of recurrence should be more than 60%. So just having only 1 unprovoked seizure cannot label as epilepsy. The third one is 3 years old child presented with new onset 3 episode of seizure.
The slide is not moving. Sorry, doctor. I think
Sorry.
the slide is not moving.
Oh, so can I share again? Can I share it
Can
again?
stop the presentation mode, maybe?
Okay.
Sorry for interrupting.
No problem. No, sorry. So is that visible now?
Yes, yes, it's visible.
Yeah, so the answer is B. 4 years old child presented with benign neurologic epilepsy. Can we proceed?
Yes, we can.
Third question is true statement regarding atypical absence seizure. Atypical absence seizure, typical absence seizure, sorry. Usual age onset is 1 to 3 years of age, not usual age, it's above 5 years. Occur very few times per day. Usually, typical absences occur multiple times per day. Associated with post-ictal confusion, usually children doesn't have post-ictal period. So the answer is D. So 3 minutes hyperventilation will provoke absence in more than 90% of children. I think it's clear, yeah?
Yes, it's quite clear.
Right. So the next question is, there is some problem in my internet connection, so I have to be fast, I think. Correct statement about definition and treatment of status epilepticus. So as we discussed before, we have 2 time points for different type of seizure. For generalized seizure, T1 is 5 minutes, T2 is 13 minutes. For focal seizure, T1 is 10 minutes. So the answer is B. And the other options are IV diazepam should be initiated within first minute of seizure. No, it should be initiated after 5 minutes of seizure. And the first line medication for seizure lasts for more than 5 minutes is phenytoin or fosphenytoin. It's not. The first line medication is benzodiazepams or short-acting benzodiazepam. So the answer is B. Shall we proceed?
Let's proceed, yes.
Yes, doctor.
Okay. And the last question, which of the following is true about simple febrile seizure? Onset is generalized. This is a true answer. These usually last for more than 15 minutes. That's a feature of complex febrile seizure. Focal motor seizures are features of a complex febrile seizure, not a simple febrile seizure. And there is a 50% chance of developing epilepsy. No, as you discussed before, only the chance of having epilepsy is only 1 to, we can say 3%. That's equal to the general population. So the answer is A.
Thank you very much, Doctor.
Thank you. Thank you. Thank you.
I'd like to say again, thank you for preparing this well-equipped presentation and giving us these questions. Our dear participants, thank you for participating. We will have our next session after 2 weeks. Dr. Endayen, I'd like to say again, thank you very much for presentation, for your excellent presentation. We will definitely meet up for our next presentations, and we'll make sure to collaborate again to have similar excellent presentations. Thank you.
Thank you very
Thank you,
much.
Dr.
I really
Endayen.
appreciate it. Thank you.
Thank you. Thank you, participants.
Okay.